Dr. Panigrahi, sir. Uh, at the outset, I must thank Dr. Alok and team NUCD for this great opportunity. So I am going to share my presentation. And as sir just mentioned, I am going to speak on can newer treatments for obesity and early diabetes replace bariatric surgery? Sir, can you see my
Yes,
presentation?
yes, yes. We can see clearly now. It is full screen. Please continue.
Okay. So I don't have any disclosure for this presentation. So we know that current strategies for management of diabetes include basically ex- they include dietary advice or dietary behavior, modifications in the lifestyle, increasing physical activity, improving diet, behavior therapy, and if nothing is working, all these are not working. We were thinking of earlier addition of this. It doesn't seem to be working here. This slide.
It
Okay,
has come now.
that is moved.
Pharmacotherapy.
So, and combination with pharmacotherapy. And if it doesn't work, then we go to bariatric surgery. Now, we know that with more and more data coming, that incremental weight loss is associated with greater benefit. So if we are able to achieve 10 to 15% weight loss, we are able to not only put diabetes in remission, we can reduce the cardiovascular risk, we can reduce cardiovascular mortality, we can improve cardiac function, and we can improve the risk of NAFLD also. But the challenge has been the amount of weight loss that we were able to achieve with medical options early. So lifestyle interventions could give us a weight loss in the range of 3 to 8%, which was again not sustainable most of the time. The initial intervention started with gastric band, which gave us weight loss in the range of 15 to 20%. But then we got bariatric surgery, gastric sleeve, and gastric bypass, giving us weight reduction going up to almost one third of the total body weight. Now, difference between medical management and surgical management was big. With pharmacotherapy and lifestyle interventions, we were able to achieve about 10 to 12% weight loss at best, while the surgery gave us weight loss going to 30 to 35%. So the gap was very big. That is why bariatric surgery was becoming more and more popular. Another thing is that earlier medications that we used for management of diabetes were associated with significant, risk component or significant adverse events, and therefore they were banned one after the other. And the latest grave in the graveyard was of lorcaserin, which, despite being introduced in the market and despite being shown CV safe, finally showed some increase in the risk of cancer and finally abandoned. Now, the only approved drugs that we have in India are Orlistat. The other FDA approved drugs are phentermine topiramate combination, naltrexone, bupropion, or liraglutide 3 milligram. These were the drugs available till about 2 years back when we started getting new drugs. Now, if you look at the comparative weight loss with these molecules, the best that you could get was what 10% weight loss, anything between 5 to 10% weight loss. And that was the best that we could get. And we had to, then medication had to be continued to sustain it. In addition, there were side effects with these medications also, and tolerance was not very good. Now, then we started getting better molecules which were acting on the GLP-1 receptor, and we started with a new era of GLP-1 receptor agonists in the management of obesity. Now, we know GLP-1 receptor agonists like liraglutide, dulaglutide, we have been using for diabetes, and they have been shown to induce weight loss also because of their central effect in hypothalamus and also by slowing gastric emptying. And the composite benefit of reducing glycemia and weight actually, made them a preferred drug for management of diabetes. And we know most of the people with type 2 diabetes have overweight and obesity. Now we know the GLP-1 effects. They mainly act on the pancreatic beta cell to increase insulin secretion and also suppress glucagon secretion. But at the same time, they have a direct impact effect in the central or brain GLP-1 receptors by promoting satiety and reducing appetite, and at the same time, they also reduce gastric slow emptying. So with this effect, there is significant reduction in appetite and hunger. So the first prototype that was central acting GLP-1 is liraglutide, which acted on central GLP-1 receptor in the arcuate nucleus, thereby activating the PONC cart pathway, stimulating the MC4 receptors and decreasing the appetite. And this was the mechanism of action that you know, worked in people with diabetes and helped in weight loss. So if you look at the initial data with various GLP-1s, the best weight loss that we were getting was in the range of about 4%, 3 to 4% or 3 to 4 kilos of weight loss. Then we had studies with higher dose of liraglutide tested for people with obesity for weight management and not for sugar management. And this program was called scale studies, and liraglutide 3 milligrams was tested in scale obesity, pre-diabetes, scale diabetes, scale, in people with the obesity only and sleep apnea. And scale program showed that liraglutide 3 milligrams could give you a weight reduction going to 6%. This was the best we could get. Then we got semaglutide, and we realized the semaglutide is much better in lowering the energy intake, that means reducing the appetite. And the energy intake lowering effect of semaglutide was almost twice as significant as that of liraglutide. It, it is again a small molecule and has access to brain and works through the key physiological and well-described satiety and hunger signals. The action involves both the receptors in hypothalamus and brain. And sustained clinical trial program was initially started to assess the semaglutide action and evaluation in people with diabetes. And this is the whole sustained studies which were in people done in people with diabetes. This was tested as monotherapy versus placebo versus different molecules and in combination with different molecules. And the interesting part was that not only this was more potent in giving a A1C reduction going to the range of 1.5 to 2%. In addition, there was about 5% reduction in the weight, and significantly higher number of people achieved weight loss of more than 5% when they were treated with semaglutide. Uh, semagl- then we got oral semaglutide, which is Rybelsus in Indian market, and we got the pioneer trials, which evaluated oral semaglutide in management of diabetes. And again, in various settings, not only there was significant reduction in the A1C, there was also significant reduction uh, in the weight. And again, with oral semaglutide, most of the studies showed that one could achieve a weight loss of going to 5 kilograms and more number of patients as compared to those not on semaglutide were able to achieve a weight loss of more than 5%, which is considered significant. So, proportion, this is the slide which is showing the patients achieving a body weight loss of more than 5%. This was, then this was the step from where the further studies took off. Okay. So this led to the further development of semaglutide in STEP program. STEP was basically semaglutide treatment evaluation, people with obesity, and higher dose of semaglutide was tested in management of obesity. So STEP has step four trials. Step one was for management of weight in obese individuals. Two was in people with diabetes for obesity management. Step three was in combination with behavior therapy, and step four was the continuation of therapy to sustain weight loss. And interesting thing was all these trials showed that with semaglutide 2.4 milligrams, we could achieve a weight loss of about 17%, which was very, very significant and much better than the other drugs that we were using till that time. And not only that, semaglutide also gave a A1C reduction going in the range of 2 to 2.2%. And people who had more than 10% weight loss had in people with diabetes, they had a A1C reduction going to 2.2%. And the baseline A1C was only 8%. So with this reduction, all these people were having A1C going to about 6 to 5.5 to 6%, which was complete remission of diabetes. Not only that, this also showed benefits beyond weight loss, which included reduction in the blood pressure, improvement in the inflammatory status, better glycemic control, and better quality of life. So step 4 showed that we have to continue therapy to sustain weight loss. If we discontinue therapy, the weight would come back. And it is expected, we have know this from earlier trials with multiple drugs and lifestyle interventions also, that you have to have a sustained therapy in place to induce weight loss and then sustain weight loss. If you look at the side effect profile, except for the GI side effects, there was no major risk. There was no increase in the risk of acute pancreatitis or malignancies in these trials. And the post-hoc analysis showed the safety profile was pretty good, except for the GI upset. So we got semaglutide 2.4 milligram approved worldwide, and we got approval in India also in 2021, though it has not been introduced in Indian market till now. Then we got tirzepatide, which is dual GIP GLP-1 receptor agonist. This basically this molecule is created by combining two components, GIP and GLP-1, through a process called coagulation, and was the first data was presented by Matthias Schaub, who was recently in India, brilliant scientist, and he combined these molecules to give synergy not only in improving weight loss, but also in reducing the side effects. So if you look at the GIP receptor mechanism, you will see that it reduces food intake, it also reduces nausea and improves body weight and increases energy expenditure, which are the effects are very much synergistic or complementary to GLP-1 action. And the initial clinical trial data with this molecule showed that people who were treated, people with diabetes who were treated with tirzepatide, not only achieved a A1C reduction going to about 2.4% at higher doses, they also lost weight going to about 12%, 11 to 12%. And this was initially, this was then further studied in SURPASS studies. So SURPASS program was for study of tirzepatide in people with diabetes and different settings. So SURPASS first was monotherapy, SURPASS 2 was versus semaglutide, versus degludec, versus glargine, and so on. And all SURPASS studies showed that if you are using 10 to 15 milligram of tirzepatide, you could achieve a A1C reduction going to about 2.5%. Now imagine if you are having a baseline A1C of about 8.5%, you are going to A1C of 6%, which is remission of diabetes. Not only that, the number of people who were achieving A1C less than 5.7% were in the range of 30 to 60%. And not only that, again, there was significant weight reduction going to about 13% weight loss, 13 to 15% weight loss with tirzepatide 15 milligrams. The side effect profile was similar to other GLP-1 receptor agonists, and this led to further study of tirzepatide in people with obesity in a program called SURMOUNT. And now we have data from SURMOUNT 1, 2, and 3 trials already available. Surmount one involved tirzepatide once weekly for management of obesity and again showed significant reduction in weight going to about 20%, significant reduction going up to about 20 to 20.5%, and almost all patients achieving weight loss of more than 5%, almost 80% achieving more than 10%, almost 70% achieving weight loss of more than 15%. Surmount 3 Surmount data further again, is from Surmount 3 is available now. And again showed not only there is significant 20% or 21% reduction in body weight, higher percentage of people are achieving weight loss. And if you are having ongoing therapy, you are able to sustain weight loss going up to about 25% in people with diabetes at the end of people with obesity at the end of 1 year. Now both semaglutide and tirzepatide are approved, and tirzepatide now is approved for weight loss also in US, but it is not available in India. Then we have, amylin analogs, which is cagrilintide, and we know that amylin is a co-secreted neuropeptide with the insulin, and studies with amylin have shown that it reduces weight. So cagrilintide showed weight loss going to about 10%, and now it is being studied in combination with semaglutide, and studies have shown very promising results going to up to about 17 to 20% weight loss. Then this was a new molecule which was data was presented at the ADA meeting last year called retatrutide, and it is a triple, agonist. It is a triple hormone agonist which has combination of effects of GIP, GLP-1, and glucagon receptors. And the initial data was presented to assess the efficacy, tolerability, and safety of retatrutide for weight management. This was done in people with BMI in the age group of 18 to 75 years, and they excluded people with diabetes from this study. And they studied various doses ranging from 2 milligrams to 12 milligrams. And the interesting thing was at the end of 24 weeks, the people who were on 12 milligrams achieved a weight loss going to about 20%. But if you look at the follow-up data at 48 weeks, the weight loss was about 25%. And the absolute weight change was in the range of about 26 kilos in people who were receiving 12 kgs. Now, other thing is almost 100% people achieved weight loss of more than 5%. 90% achieved more than 10%, 80% achieved more than 15%, almost two-thirds achieved more than 20% weight loss, almost half achieved more than 25% weight loss, and almost quarter achieved more than 30% weight loss. The question is the long-term safety of these molecules. Now we have the semaglutide CV outcome study also in place, and this was, study which looked at the impact safety of semaglutide, injectable semaglutide once weekly, added to standard of care in people with obesity. So 3 years follow-up was there, involved more than 17,000 patients. Mean duration of follow-up was 39.8 months, and mean duration of drug exposure was about 35 months. Not only statistically significant, reduction in the risk of CV endpoints, the study showed that injectable semaglutide 2.4 milligram was superior to placebo in terms of reducing CV endpoints, CV death, heart failure endpoints, as well as the 3-point composite. So select trials showed that in patients with pre-existing cardiovascular disease and overweight or obesity, but without diabetes, weekly subcutaneous semaglutide at a dose of 2.4 milligram was superior to placebo, reducing incidence of death from CV causes, non-fatal MI, non-fatal stroke in a median follow-up of about 40 weeks. Now, back to this slide. So earlier we were able to achieve about 12% reduction with at best with pharmacotherapy, but now situation has changed and we are matching the weight reduction achieved by bariatric surgery. So take home is that availability of newer weight management drugs has made it possible to achieve weight loss similar to that achieved by bariatric surgery. And medical management has significant advantages. You don't need surgical skills. You don't need hospitalization. There is no associated mortality whatsoever. In fact, there is a reduction in mortality with medication. There is no surgical infrastructure required. There are no post-op complications. And there is no, kind of limit to resources. It is scalable. Surgery, to scale up surgery, you have to train everybody to do surgery, which is not possible. But to use a medication, it can be, the education be disseminated and, use can be scaled up. So surgery, we know surgery always starts with a basic surgery, and then you go to advancements like laparoscopic surgery, and then finally you have achieved robotic surgery, now increasing safety, but still there is mortality. And also one has to remember that end of any invasive therapy is a non-invasive therapy, which is a pill or a capsule right now, and maybe in time to come it will be something like gene manipulation. So with that, I end my presentation. We are in an era where we are likely to replace bariatric
Thank
surgery
you. Thank
with
you.